So today we're going to have a look at a shoulder assessment. With the shoulder assessment, it's one of our most complex joints, so we want to be able to be pretty thorough. And we'll look at the different types of injuries or possible diagnoses, whether it's an impingement problem, an instability problem, whether it's an injury that's been caused by the trauma, and what we look at with that. So the first thing we do, Lockie's already got his shirt off so that we can have a look at his posture. We're looking probably from the front at alignment and the height of the shoulders, looking at the lines of the clavicles, and looking a good look at the AC joints, looking at muscle bulk through the traps. Is he round shouldered? Is he quite upright in his posture? If you can turn side on, Lockie, so then if we look side on, we can look at even lumbar posture, because lumbar posture and position can influence the position of the scapula and the shoulder blades. Lockie's probably a little bit rounded, but he's not excessively rounded. And if we turn around, looking from the other direction, we're looking again at muscle bulk through the scapula. We're looking between the scapula and the spine, so looking at rhomboids and the traps. Looking, and even by palpating, feeling where the lower border of the scapula is, medial border, like is it sitting further forward on one side than the other, or like if you look that side and that side, and I pushed him forward there, that's not how he naturally is, but we can see a difference there. So looking at asymmetries, looking at the spine, is there a scoliosis or is it straight? Because that can influence the position of the scapula on the spine. Even going down and looking at pelvis level, sometimes someone might have a significant leg length discrepancy that influences the position of the spine, creates scoliosis and therefore dysfunction up around the shoulder as well. Looking at head and neck position, because that influences some of the positions of the scapula. Just turn around and face this way again. When someone has a really rounded shouldered posture, if you can drop into that rounded shouldered posture there, Lockie, when someone's like that, they're often really tight in the front, in their pectoral muscles, and then they're often also tight through the upper traps and the levator scap. And then we call it the postural cross. So on this side of the cross, tight, and then on this side of the cross, they're weak. So generally weak in the deep neck flexors. And if you turn around again, Lockie, if they're that rounded shoulder position, lengthened muscles are generally weaker muscles. So the rhomboids and the lower trapezius, because of that scapular position, are going to be generally weakened and lengthened. So from our postural assessment, we're getting hints about what are some of the things that might contribute to a shoulder joint problem. Okay, turn around and face the camera again, Lock. So if we then go on to range of movement testing, like if you can point your thumbs up like that, I'm just going to get you to reach forward and up above your head as high as you can go. And we're looking at one side versus the other side. Any pain with that, Lockie? I'm just going to put a little bit of pressure there. Any pain when I do that? I'm just going to come down to the other side. And so we're doing an overpressure there, and come back down again. And then if you turn your thumbs out to the side, Lockie, now I want you to go out to the side and up above your head. Yep, and come back down again. And can you turn around and face the wall? This time I'm going to get you to do the same movement, out to the side and up, and down again. And just do it slowly. And we're just looking at scapular mechanics here as well. There's a little bit of asymmetry between what happens there on the right side and the left. One more time, Lockie. Any pain doing that? So the right side, it rotates up a little bit earlier than the left side. So there's a little bit of difference between the sides, and that may or may not influence what's going on with the pain. Okay, so if you turn to face me again, so this time with your thumbs up like that, I want you to turn your arms out to the side. So we're looking here at range of motion. How much external rotation is there? Is it different from side to side? I'd say that he's probably a little bit less rotated out on that side, but not a lot. We can add in a little bit of overpressure there. Any pain with that? That side. Any pain? That's fine. Okay. So now if you turn around and face the other way again, Lockie, I want you to reach around behind your back with your left hand and reach up as high as you can. Okay. And now the other side. Okay, so there's probably a couple of centimetres difference. It's a little bit tighter on the right side than the left side. Can you reach around the back with both hands together and just reach up? Yep, and again, it's a little bit harder to see there. You probably saw that difference more with the one hand at a time. When someone's doing this as well, you can have a look at what's happening to the scapula. Is it winging away from the, and bring your hands back down again, is it winging away, or are they having to anteriorly tilt or protract their scapula more on that side to get that rotation? And that might mean that there's some stiffness or tightness within that internal rotation movement of the shoulder. Okay, can you turn around this way again, Lockie? This time I'm going to get you to reach across your body as far as you can. And any pain with that? And now the other side. Okay, and we're looking at how far across the elbow can go. We're looking for reproduction of symptoms. We might add overpressure here. If someone could only go halfway across and it was painful, and they said that it was painful here, then that is one of the signs that if it adds up within, if they've had a mechanism of falling onto the point of their shoulder, and we're suspicious of an AC joint injury, horizontal flexion, a restriction and pain with that is going to be something that ticks another box to say that this diagnosis might be an AC joint injury. Okay, I'm then going to do what we call an impingement test, or Hawkins-Kennedy test. Can you stand so that you're facing towards me, Lockie? I'm going to get you to bring your arm up to 90 degrees. I'm just going to put my arm under your arm, and then I'm going to rotate your hand down. And any pain when I do that? Okay, and I'm looking at how far Lockie's forearm rotates down. You'll be able to see it probably a little bit easier when I do it on this side. So as I'm rotating down, I'm looking at the angle that's made here, and on this left side is probably 60 degrees of internal rotation there, and on this side I'd say there's probably 45 to 50. So there's a difference there, but we're also correlating that to, is there pain reproduced? So if there's pain reproduced when we do that test, then we're suspicious that there's structures within the subacromial space that may be irritated. So those structures, the bursa, the rotator cuff tendons, the tubercle, the greater tubercle, the long-headed biceps. So they're all structures that may be irritated or sensitive because pain's reproduced when we do that. So then that helps us to tick another box here. It might be an impingement problem if it's pain here when we do that test. If someone, when we do that test, got pain back here again, then you're again a little bit more suspicious of the AC joint and structures in underneath it. Okay, so now we're just going to do some resisted tests. So if you bend your elbows, Lockie, turn to face towards me, and with this one I'm going to get you to push out to the side against my hands. Any pain when we do that? Okay, so this is working the external rotators. It does fire up supraspinatus, but it's mainly assessing infraspinatus. If you put your hands like that and you push inwards against my hands, okay, this is a test for subscap. There's another test that we can do for subscap called the lift-off test. So you can put one hand behind your back, Lockie, and I want you to lift your hand away from your back. Any pain doing that? Okay, just push, keep your hand there. Now lift away again and push against my hand, so I can add a little bit of resistance there as well. So that's subscap, and you do that again on the other side, and you're comparing sides. If someone can't lift their hand away from their back, then it's highly suspicious that they've either got a tear in that, or it's very painful, that subscapularis muscle, or they're very weak there. Can you now put your hands in that position? Come out to the side a little bit. Now push up against my hands. Any pain with that? So with this one, we're testing the supraspinatus tendon for strength. If someone has pain with that, but they've got reasonable strength, then there may be a tensile injury within that. They may have strained their supraspinatus. If they have a loss of power, so if I do that and Lockie drop that right arm, if that arm just drops down, then it's highly likely that that person has a tear within their supraspinatus tendon or one component of their rotator cuff. And maybe they've got lots of pain and that's inhibiting it and they don't want to hold it up, but that's a test for the strength and integrity of the supraspinatus tendon. Okay, if you turn your hand like that for me, Lockie, and then you push forward for me like that. We're testing with that the biceps, so we're contracting the biceps, there's flexion as well, and therefore if someone's got pain in this area, then and they're weak in that area, they may have had an injury to their long-headed biceps. The other thing, and it probably happens more in older people, when we're doing our observation, if we look at the biceps and instead of having a long biceps there's a bulge down here, then we've got to be suspicious of a rupture of the long-headed biceps. Again, those people in your subjective are going to usually have a description of something popped in my shoulder, and ever since that happened I've had this lump down in here. It looks a bit like a Popeye muscle. So again, in your observation, when you're looking at the shoulder, look down a little bit as well to look at the muscle tone and the muscle bulk around the biceps. Okay, so most of those tests are looking at the strength test. We're looking at the rotator cuff. Do we have a tear, or is there pain when we contract that muscle? And that helps us to build a picture towards have we had an injury to the rotator cuff. If we've got good strength, then it might be that the structures within the subacromial space, there might be a tendinopathy rather than a significant tear, which is a accumulation of micro tears within the tendon rather than an acute tear. And again, a subjective assessment where you've asked what happened. If someone's had a high force trauma, then you're going to be more suspicious of an acute tear of the rotator cuff tendon if they can't lift their arm or they can't move their arm. If when Lockie did his abduction range of movement test, he went to lift his arm and it wouldn't, like he's hitching his shoulder and it's only going that far, then you're going to be really suspicious of a rotator cuff tear that's happened from the acute trauma. Or there could have been a fracture of the great tubercle. That's when you start to go off and look at further investigations like X-ray and diagnostic ultrasound. If there's been a really significant trauma. Obviously, as we're going along and we're doing our testing, we don't do every single test on every single person. Irritability is something you've got to be mindful of. So if someone is really sore and they're saying that their pain's 7 or 8 out of 10 after you've done a couple of movements, then you might have to stop at that stage and do something to treat the pain before you can get a little bit more information. Or it might be that you want to send someone off for an X-ray because the things from your subjective and your simple range of movement assessment have said this person might have a fracture, and I want to rule that out before I go and do anything that could potentially make that worse. So sometimes when you're doing your assessment, you've got to stop and say, okay, now's the time to get more information before we go any further. And your advice to the patient is, we're going to put you in a sling until we know that we don't have a fracture of that shoulder, or that if they're really sore, they're probably already in a sling anyway. Okay, so have I missed anything there in the tests? Probably the other one, the label test. And label tests aren't very accurate or specific, but look, if you've got someone who's got a clicking or a clunking and they've had a history of the shoulder being a bit unstable or dislocating or subluxing, or problems with overhead throwing or something like that, then if you turn to face that way, then Lockie, bringing the elbow up into this position and then rotating inwards and outwards in this position. If we're getting a clunking and then doing it with a bit of compression as well, then we're looking, and even with our fingers on the shoulder here, we can be feeling can we feel a clunk? Or the patient's going to describe whether they've got a clunky or a clicky feeling with that. Okay, so what we might do now is get Lockie to come and lie on his back on the bed. So if you lie on that side of the bed, Lockie, I'm just going to bring the bed up. Sorry, can you turn around so he gets up this end? And I might get you to turn around to the side there. So some of the, actually Lockie, can you sit up first for me? Right near the end of the bed. In terms of our instability tests, a bit like you can do an anterior draw or a Lockman's test on the knee, an accessory joint assessment in sitting. So if you put your fingers on here, hand over the scapula, and you push the humeral head backwards, or with your thumb in behind, you push the humeral head forwards, you can get a little bit of a feel of joint play. So if someone's got a really loose or unstable joint, then you're going to have a bit of a feel of it there. And again, you can do the same. We always compare left and right side, so a little bit of an idea of joint play. The other test that you can do in this position, you put your fingers just over the end of the acromion and you feel where the top of the humeral head is, and then just relax your arm there onto your hand, onto your thigh, and then if you pull down, you see pushing down in that direction on the forearm, you're looking for what we call a sulcus sign. So if someone's got an instability problem and a really loose joint, what happens is that you can feel like you can almost stick your fingers in there underneath the acromion there as the ball gets traction down in the socket. So again, you compare sides with that. It's something in someone that's got a hemiplegic shoulder, like if we go away from musculoskeletal into a stroke patient, if you've got someone with a really flaccid limb, it's a good test to do to look at, like if they're getting a subluxation like that, you've got to be mindful of that when you're doing things in your treatment of that person's shoulder. So yeah, just your anterior and posterior glides there. That can also, like if when you're doing a posterior glide, it just feels really stiff or they've got a really prominent humeral head, it might be that if someone's got a stiff shoulder, that makes you think, well, maybe they're really tight in that posterior capsule. If their humeral head's a bit proud, a bit too much forward, then you might do a manual therapy technique to try and do some posterior gliding to get better centralisation of the humeral head as a treatment technique. So we're doing that as an instability assessment. So is it too loose, but also is it too stiff? Like does it not go back very easily? And that might be something in the stiffer shoulder that you look towards addressing with manual therapy. In someone that's got a loose shoulder from that assessment, it's like, well, they're too loose. I don't want to loosen them up anymore. We need to strengthen. So when we're looking at how we treat these sort of shoulder conditions, often there's so much to look at, so much you can assess, but you've got to try and simplify things as much as you can. And I like to categorise people into an impingement type problem, a stiffness type problem, so your adhesive capsulitis, your frozen shoulder, or people that are generally tight or stiff, their body type is tighter or stiffer, they might need loosening. Someone who's really loose, we're then going to look at mainly strengthening things for. And then someone that's got impingement, the impingement might be because their humeral head's flopping around too much, they need strengthening, or their impingement might be because they're stiff and restricted, and they need loosening up in that direction, but then they also need some strength-based stuff as well. So yeah, I suppose while you're in this position, it's good to do maybe your palpation assessment. So if someone's had an acute trauma, you might want to palpate along the length of the clavicle, and then coming out to where the clavicle meets the acromion. So this is where your surface anatomy is really important. So spinal scapula here coming around to the point, coming along the clavicle, and then at that point there, that's where the AC joint is. So if someone's had a fall onto the point of the shoulder and they're really tender there, then that combined with that horizontal flexion test might tell you that they've got an AC joint injury. If someone you're also looking here at the position of the acromion. If the collarbone or the clavicle end is sitting up, then that's going to help you with your grading. If there's been the displacement and elevation of the end of the clavicle, then it's either a grade 2 or if it's really sticking out, a grade 3 injury. So our classification of things is determined by, is there a step deformity here at the AC joint? So yeah, you're looking at probably palpating for bony tenderness first, if it's been a trauma. If it's been a different mechanism of injury, it's unlikely that you're going to have a fracture, but it doesn't hurt to run your fingers over the AC joint. Some people might have, an older athlete or an older person might have osteoarthritis of their AC joint with some osteophytes that are encroaching into the subacromial space, and that may be what's one of the things that's contributing to their impingement symptoms. If we then come into this area here, go onto the coracoid process there, our short-headed biceps attaches to there. Also our pectoralis minor attaches to there. So sometimes, people are really tight in their pectoralis minor. If I'm suspicious the pectoralis minor is tight or even got some trigger points, I always ask people, say to people, or show people on a chart where pectoralis minor goes, because it goes on to the second, third and fourth ribs. It's under the breast there. So if you're going to palpate in that area, you want to warn people or tell people why you're going into that area, particularly with the female, but for men as well. And then if you're palpating pectoralis minor, you're looking for a ropey tightness through that part of the muscle there. In the your long-headed biceps, you might just rotate inwards and outwards to make sure that you're feeling that you're in the bicipital groove there. And again, a lot of people are tender or sensitive on that that part of the biceps as well anyway. We then come further around and we're getting onto the greater tubercle, so where the supraspinatus attaches. If they're tender in there, and that correlates with a positive resisted test, a supraspinatus test, or your abduction test. Actually, I didn't do abduction before. If someone is struggling to lift their arm out into this position, then you can test supraspinatus just by push out with the elbows there. You can get them to push out there. We did external rotation before, but we didn't do just static abduction. And then as you come around a bit further to the posterior part of the greater tubercle, where I'm pressing with my thumb, we're then looking at the attachments of your infraspinatus and your teres minor. I often come around and into the actual fossa where infraspinatus is. Obviously you've got deltoid there as well. You're getting a general feel for muscle tightness and also tenderness. Sometimes people are really tight and tender within that infraspinatus problem. Generally more with your people that are stiffer and tighter than your instability type patients. All right, so they're the main palpation things that I'm looking for. AC joint, bony structures. Obviously when we're pressing over here, we're pressing over the greater tubercle as well. So again, if you're a bit suspicious of fracture and you press on there and they drop their shoulder and say, get your finger off me, then you're starting to think maybe there's either a supraspinatus rupture or a supraspinatus tendinopathy or a fracture, depending on the mechanism of the injury as well. Again, if someone has a bursitis, they might be generally a bit tender around this area, but the bursa is in underneath the subacromial arch. So a bursitis, you don't necessarily. Often people go, yeah, look, I've been pressing around, I've been trying to find where it's sore, but I can't find it. It feels like it's in there. It feels like it's in under there somewhere. And again, that's where your subacromial bursa is. So people are pretty intuitive. They sort of know where their pain is a lot of the time. Some people are hopeless, but a lot of people say, well, yeah, I've been trying to find it, and it feels like it's in deep. So if it feels like it's in deep and with your palpation you can't find it, then maybe it is a structure in under that subacromial space, or maybe it is a structure within the joint. Maybe it's the joint surface. Someone might have, an older athlete might have some sort of chondral damage. They might have some early arthritis. They might have some osteophytes in the AC joint that are causing something that's deeper into that subacromial space to be squashed and irritated. Okay, so if we get you to lie down on your back now, look, so wiggle down that way. And so in this position, I'm just going to bring the bed up a little bit higher. We can look at things like our passive range of movement stuff and then our instability tests. So with our passive range of movement, I'm just going to take Lockie. So if he was unable to elevate his arm past about 20 or 30 degrees, and I'm suspicious of a rotator cuff tear, and then I put him in this position, I'm passively moving it, and he's got full active range, full passive range, but he didn't have much active range, then it tells you that there's a muscular reason why he couldn't do it. If the joint's happy to go through that range, but when he tried to contract the muscle to do it, it couldn't, then that sort of helps you to hone in on a more active reason that they can't do it. If I'm looking at an instability test, I'm going to take Lockie up into this position here, and I'm going to put my hand over the humeral head. Okay, so in this position, I put my hand over the humeral head. I then rotate it up, and I'm looking at his face. For some people, even when I'm doing this, if they're apprehensive there, that's a positive apprehension test. If I take my hand away and he freaks out, that's allowed that anterior translation. If I put it back on and it feels better, that's a positive sign for an instability issue. Again, some people you might be able to take out here, and you can wind them up and you can actually take them down to like 20, 30, 40 degrees beyond neutral. Again, that is what happens with your hypermobile people. I'll also look at internal rotation, external rotation in this position, and like some people will be really restricted in internal rotation. Most people you would hope to have 90 degrees that way and at least 70 or 80 degrees that way. If someone's really struggling to get past there in this position, then they've got a real stiffness problem. Okay, so whilst that test I'm looking mainly for instability, I'm also looking at what's their range like, what's it like compared to the other side. So we might, in those people that come in with insidious onset of pain, sometimes you're doing just about every test to try and work out where there's difference between sides. Okay, while I've got Lockie in this position, if we have someone that again has a stiffness issue, like if their symptoms are a stiffness and they're really restricted, and when we get to here, they're starting to go up into a scapular elevation, and like you're not even getting, like normally you should get 120 degrees of movement in the glenohumeral joint. If we're getting nowhere near that, this is where in that population we might then look at inferior glide and AP glide. You can also look at PA glide in this position. So a bit like we did in the sitting position, we can do a manual accessory glide assessment of their shoulder, and this then for me often becomes one of my manual therapy treatment techniques for people that have got a stiff restricted shoulder. So I might do some anterior to posterior AP glides on the shoulder. I would call this a grade 3. If I'm going in deeper, more firm, maybe a 3+, or if it's a small oscillation, a grade 4 plus. And same with my inferior glide. And I can do that in different degrees of rotation, depending, and you can see how I'm sort of holding Lockie's arm there and controlling that, and then I'm applying my force through my right hand, but I'm stabilising him with my elbow here, my hand here, as I do my inferior glide. So sort of getting away from assessment there, but sort of just utilising this opportunity to show you with a stiff shoulder, that's what we might do. If I found that Lockie's got an instability issue, then I'm going to be thinking, I don't need to mobilise that shoulder, it's too loose. We need to get him up and start doing some strengthening work with him. All right, he might be a subluxar dislocator. I think they're most of the things that I would look for in an assessment. Sometimes you might go to a few other special tests, but they're probably the go-to things that I use in my assessment. Do you want to just sit up again, Lockie? So essentially, if we go back to the sort of things that we're wanting to look for in our assessment is, do we have someone that's got a stiff shoulder, an unstable or a loose shoulder? Are they getting impingement? Or have we ruled out a rotator cuff injury, ruled in or out a rotator cuff injury, whether it be a tear, a tendinopathy? Is it something that we need to investigate? Do we need an x-ray to rule out a fracture? Maybe if we've got someone with an older shoulder, we might be looking for osteoarthritis. Is it reasonable to get an x-ray to see whether they've got osteoarthritic glenohumeral joint or an osteoarthritic AC joint? We've looked at posture, we've looked at the influence that that may have. So from all of that information, then we need to use our clinical reasoning to come up with a diagnosis, a provisional diagnosis. Then we're looking at, do we have, like the patient that's come in, they want to know what's wrong with me, how long it's going to take me to get better, what can I as a physio do to help, what can I do myself, and how long is it going to take me to get back to doing what I want to do, whether it's playing sport, working in the garden, being able to write or use a computer, depending on what are those things that that person functionally needs to do. And then we develop a treatment plan to do that, and we can talk about that in another video. Hope that's been helpful. Obviously, yeah, ask questions if you've got any questions, and yeah, hopefully that's really helped with your ideas around assessment for shoulders. Cheers.